in doing basic self-care tests like activities of daily living, and even risk for initial hospitalizations. So when we think about the health issues in an aging population, they get both much more complicated and require a whole new set of diagnostic and clinical skills to think how to handle all of these in the same individual and how to do prevention effectively across the spectrum of issues. So that for older adults, aging is about a number of things. At a physical level, older adults' health status changes sometimes rapidly and often progressively over time, going through many different health stages, from robust to having one chronic disease that people are living with, to perhaps adding in many other chronic diseases, being frail or disabled or dependent or at the end of life. And that suggests that not only is there wide variability in health status that has to be dealt with, but one older adult is not the same as another older adult in terms of what their needs are, whether it's for prevention or care. And so older age has many, many faces, and as prior speakers suggested, the heterogeneity of people as they get older demands the ability to really tailor prevention and care to the needs of that individual. The third issue that has to be dealt with is how we promote the health of those living with HIV, because of HIV particularly. I know you're going to be talking about that all day. I'll just make 3 points in that regard, and I know this group can take it from there, but obviously it's already been said that HIV is now a chronic disease for many people who have the benefit of receiving therapy, and requires the application of chronic disease care and principles. But beyond that, the care of people with many other health problems at the same time, or at risk for health problems resulting from medical therapy itself. And then superimposed on that, perhaps related to their HIV and care and consequences, but perhaps related to getting older, are all of the geriatric conditions that I've just mentioned and more. And all of these actually have the potential to be additive or even interact with each other to cause joint problems or concerns. Some of the issues that I mentioned, like frailty, play out in HIV specifically. Here's some recent data from Desquilbet, which tried to construct a frailty-related phenotype in the max cohort because we didn't have exactly the data that geriatricians use to characterize frailty. But in this approximation of frailty, what you see is that the longer HIV infection has been around in an individual, here you see from 0 to 0 to 4 to 4 to 8 to 8 to 12 years of HIV infection duration, the greater the likelihood that the individual is frail, going from a risk of 3-fold increase to 15-fold increase in frailty prevalence with increasing duration. And a 55-year-old man infected for less than 4 years has the same frailty type prevalence as a 65-year-old man who's not infected. So there are age-specific and health needs-specific public health and healthcare approaches, and they all matter. And all of them, I think, have the need to be addressed both in the public health and the medical care realm. So the fourth and final point I want to make is that an older population is going to require new approaches to both public health and healthcare delivery, and new approaches that remove the silos in which we currently do all of these things. We're going to need to transform our systems of both care and prevention, and we're going to need to take care of people and do prevention using approaches that are different than we would use in younger people. So the contents of prevention and care and the systems of care in which and prevention in which they're embedded need to be transformed. The locations in which we do it need to shift. We need to learn how to integrate public health and medical care approaches so there's prevention in both sectors, so that there's care in both sectors, and so that everybody knows who's doing what and talks to each other. We need a workforce that's geriatrically knowledgeable as well as HIV expert, and we need to think about the environments in which people live. Housing, the design of our cities, the quality of our air, all these things matter for everybody, but they certainly matter as people get older and live with chronic conditions. And finally, we need to have the opportunity to think about social institutions differently. So how can we create ways that people can, who now have a third age to live that never existed before in human history, an age in which people remain active and engaged, perhaps after retirement, perhaps they're working but into their 80s and 90s. How do we create roles in which they can be giving back to society and making a difference in terms of the legacy they want to leave? That we do not have those social institutions. And I would suggest that we have to work hard at every one of those levels. The Institute of Medicine recently put out a very important report on retooling for an aging America, which said that the healthcare system is not ready for the chronic needs of older adults. I'm not going to go through the details, but we know a lot about geriatric models of care across the whole continuum that I described. There are specific models of care which could serve patients with HIV, as well as older adults generally, really well. The wheel doesn't have to be reinvented. And we now have evidence-based interventions for geriatric syndromes that improve outcomes, whether it's fall prevention or frailty prevention. We know how to do a lot of this. It could serve the needs of patients with HIV really well. We know that even in the frailest nursing home patients, that staying physically active, doing strength training matters. In the frailest nursing home patients, you can double muscle mass and improve walking speed and function with exercise. Do we do it? Probably not. And we know that there are building blocks for effective health promotion for an aging population that start with a disease focus at the bottom. I'm sorry you can't see this well, but a huge number of building blocks for effective prevention for all the issues that confront people as they get older, whether they're depression and loneliness or falls or access to care or how to stay meaningfully engaged. And we have to confront who's on first in public health. About 5 years ago, there was a very eloquent article that was written in a journal called Public Health and Aging, which said that we have a system designed in the 1950s, before our world aged, that may not serve what we have to do to prevent health problems as people get older. The siloization of CDC and AOA and a number of other organizations that are probably represented here today means it's sometimes, to me as an outsider from the system, unclear who's on first and who's responsible and the degree to which it's possible to actually develop a coordinated, integrated approach. This particular article called for us to look hard at the way we design systems before the world aged and think about whether they really serve our public health needs for the future. And finally, New York has committed to redesigning itself, New York City in particular, to support successful and healthy aging, building on the World Health Organization key domains for an age-friendly city: housing, transportation, outdoor spaces and buildings, social participation, civic engagement and employment, ageism itself and the fear of becoming older, communication so that people know what services are available, and how we evolve our community supports and social institutions, as well as our health services, which I've already touched on, are all things that we need to take a hard look at to transform so they serve an aging population well. I would argue that if we do that, we will end up with a system that supports all ages well. Because, in fact, the complexity of needs for older adults, if addressed in a way that integrates them and really serves prevention, will serve the needs of all ages in an exceptionally exciting way, which we